Well, diagnosing an MPN in 2018 is challenging, but it certainly has improved over the years. The first key step in diagnosing an MPN is really having the suspicion that an MPN might be there to begin with. And that truly is the key stumbling block for many. There are many things that can be a sign of an MPN: elevation in the blood counts, a symptom, an unexpected blood clot, perhaps palpation of the spleen at the time of physical exam. But being able to go from those things, which can be signs of other problems or reactive states, to really going down the path of investigating MPN, that's probably the key step. In 2018, what we have is a much greater degree of ability to be specific about MPN diagnosis based on what's been learned regarding analyzing the bone marrow biopsy of patients with MPNs, as well as the presence or absence of key molecular markers, such as the JAK2 mutation in the genes, the CALR mutation, or the MPL mutation. So I'd say compared to earlier in my career, now if we're suspicious of an MPN, we can be much more certain about the diagnosis. In general, the presence of the JAK2 mutation, in particular in someone who we were suspicious that they have an MPN, they do in fact have an MPN. There is a very low, what we call, false positive rate. Now, if we were to just survey the general population, so people that we don't have a suspicion of an MPN, there are scattered individuals that may have the JAK2 mutation. But individuals that were checking it because their spleen is enlarged, or their platelet count is high, or their red cell count is high, then we're quite a bit more suspicious they do in fact have an MPN. When we think about the spectrum of MPNs, subdiagnoses like MPN unclassified and MPN not otherwise specified are individuals that live along that spectrum. And I could certainly imagine getting such a curiously worded diagnosis makes it seem very uncertain. I think we realize that historically we tried to put individuals with MPNs into one of three groups. They either had ET, they had PV, or they had myelofibrosis. So in that whole spectrum, they created criteria around what exactly is ET, what exactly is PV, what exactly is MF. The difficulty is that there's people that fall in the cracks between those terms, and that's really where those other terms really exist. What does that mean? The patient that has one of those criteria, we largely treat them depending upon how the disease has affected them. For some, they have more MF-like features. They might have more spleen, they might have more symptoms. If they have elevation in the counts, we work to control the counts. So a change from ET to PV really can be one of two things. One, it can be the individual had PV the entire time, and because of iron deficiency or other such reasons that limited the production of red blood cells, they did not have an increase in the red blood cell count. Functionally, the main difference is, particularly in those that have the JAK2 mutation, is a difference in the degree of elevation in the red blood cell count. Some have argued that JAK2 mutated ET and PV are so similar they should not be considered separate diseases. So there is controversy as to how different those two things really are. A very common scenario is women who've been iron deficient because of menstrual blood loss, which is incredibly common, don't have an increase in the red cell count even when they have PV and get labeled as ET. So I want to ask the question, is there really a change? There have been individuals that we really have seen a change, where they clearly were not iron deficient, they clearly had ET, and the disease, JAK2 mutated, started to develop more of an increase in the number of red blood cells. We don't necessarily identify this as being a sign of the disease being worse, but it is a sign of the disease just being different. And it means that we need to be more mindful of controlling the red blood cell count as an incremental part. So as we track a patient with PV, there are several things that can be a sign of disease progression toward myelofibrosis. P-vera rarely can transform into acute leukemia, but it is rare for that to occur without it first changing into myelofibrosis. So the change into myelofibrosis is what we guard against most vehemently. That includes several things. One, it includes changes in the bone marrow, but not only changes in the bone marrow. So if there's increasing in scarring in fibrosis, that is one sign. Now that alone does not mean an individual has changed. The change to post-PV myelofibrosis is really a change overall in terms of how the disease is behaving for the individual. So we find that there tend to be, one, potentially a change in the symptoms. In particular, development of certain symptoms, inadvertent weight loss, fevers, bone pain, etc., that are really more unique to myelofibrosis than PV. That's to distinguish it from, let's say, fatigue or itching, which might be present in either group. Second, the spleen clearly can enlarge as a sign of progression. And on the myelofibrosis end of that continuum, we think very significant enlargement of the spleen. Greater than, let's say, 5 to 10 centimeters below the rib cage. So it's not that a little bit enlargement means that it has progressed, but significant enlargement is very concerning for progression. 3, a drop in the blood counts, so that there was a pattern of, again, the red blood cell count being too high or the platelets being too high, and then as the marrow is changing, that elevation really decreases. Less phlebotomies or no phlebotomies, or even the development of anemia. So the change to post-PV myelofibrosis might include one or all of those features. So a short answer to the question is yes. If there's dramatic enlargement of the spleen, then I'm concerned about progression. But modest enlargement of the spleen doesn't automatically mean that progression has occurred. So an unexplained elevation in the platelets may still well be an MPN, although it is difficult to know for certain whether that is the appropriate diagnosis at this moment. There are other reasons the platelets can be elevated, ranging from infection, inflammation, after surgery, etc. In the individual that has been followed for a while, it would be typical that one of these things would have been found. So in the individual in which there's no other cause and they remain elevated, even when the bone marrow looks fairly benign, I'm still concerned that they may well have an MPN. Being 100% certain still is a challenge. Between the 3 key mutations, JAK2 V617F, calreticulin, MPL, one of those 3 mutations will be present for the vast majority, but not all of individuals. So in that circumstance, it's difficult to have a definitive answer. And what I suggest for patients is that we will need to just watch. Perhaps repeat a bone marrow in 2 years, maybe it'll be more clear. Maybe the level of a mutation is so modest it can't be picked up by today's testing. We typically are not aggressive in terms of treatment for these individuals. So we watch, perhaps we use an aspirin, but we would not initiate cytoreductive treatments with hydroxyurea or interferon or other type things until we were really 100% certain that an MPN existed. So targeted therapies for MPNs is clearly a key goal. And targeted, again, is a term open to interpretation. Is it specific for a mutation? Is it specific for a group of cells? Is it specific for a disease? We have some targeted therapies. JAK inhibition are clearly targeted against overactivation of the JAK-STAT pathway. Interferons have activity against the clonal abnormalities, although are not unique to that being the only thing that they are doing. I think the origin of this question is, are we going to be able to specifically target the mutations and either edit them or suppress them specifically? That clearly is a goal. There are a variety of different technologies that are being investigated to see how that can be done. One is one that has probably been discussed on patient forums, which is called CRISPR, where basically you go in, you could think that if your genes, let's relate it to an email. You've given an email that is a paragraph in length. There's a word in the middle that alters the understanding of that paragraph. You go and you edit out that word and you put in the right word that you need. In brief, gene editing would be exactly that. Now, the technology for doing that is not yet fully developed. And once it is, it then would need to be, it is being tested in some other different diseases that don't have the complexities of MPNs first, but certainly will eventually, I think, be an area of interest, whether it's through the CRISPR technology or some other. That approach, I think, will be interesting. What is a limitation in 2018 is that we think for many individuals, there may be more than one set of genes involved. There may not be just one word that's altered in that paragraph, but there might be different fonts, different colors, and there may be more layers of things that correction of just one thing may not eradicate the disease. So there's much new treatments and research being done for patients with MPNs and myelofibrosis. Certainly we have much more available now than we did several years ago. The standard of care for more advanced myelofibrosis, certainly I could state in the United States, is ruxolitinib. For individuals who are not going to stem cell transplant, who have enlargement of the spleen symptoms, and many patients have gotten much benefit. There are a range of additional JAK2 inhibitors that have been tested that might play a role in certain subsets of people that is inadequate. There are combination approaches looking to add other drugs alongside JAK inhibitors to see if they can better improve the disease, put it into a remission, improve anemia, etc. And then finally, people are looking at a whole range of other ways to treat the disease in an experimental way that are new. So there are many different things ongoing, but for many patients right now, they may well have a good benefit from one of the therapies we do already have. So the calreticulin mutation is somewhat distinct. It's an area of intense focus because, again, it represents a sizable but slightly different group of patients with MPNs. Some patients do better, but not all. How it is affecting the development of the disease is likely a little different. It is a different mutation in that it may be open to certain types of treatments that may not be applicable for the JAK2, meaning the JAK2 mutation is deep within a cell in a way that can't be targeted from the outside of a cell. Calreticulin has a presence on the cell surface that might make it amenable to be targeted in different ways that might be relevant for JAK2. So at the moment, none of our medicines are specific for a JAK2 mutation versus a CALR mutation. But in the future, that might change. So yes, I can definitely reassure the person who asked that question. People are very specifically looking at calreticulin mutated patients specifically, in that there may be some other treatment options that are distinct. So one, I would say I clearly am very empathetic of this concept of the stress of watch and wait with polycythemia vera. And I think it is both distressing, but it is a reflection of the limitations that we've had on the therapies available to us. So it's not that anyone really wants to wait, it's a limitation of the therapies that we have had. I do think over time, our goal clearly is to intervene earlier and earlier in these diseases, long before they become a problem. I'm very empathetic, as patients have shared with me. Well, I'm low risk until something bad happens. And then you say, oh, now I'm high risk, and now you're treating me. I don't want the high risk thing to occur. I don't want to have a blood clot to prove to you that I needed treatment to start with. I do think in the future, we will treat all patients with MPNs from the time of diagnosis. Now, whether it makes sense to do so with the medicines we have at the moment, that I don't know. Does that make sense with hydroxyurea or interferon or ruxolitinib? Maybe it does in some folks, maybe it doesn't. So I think treatment from the time of diagnosis is limited because of our therapy options. But I think that will evolve. It's no different than saying, well, you have diabetes, we're just going to ignore it. You have high blood pressure, well, we're just going to wait until you have the complications of high blood pressure, then we're going to treat it. The question is, how long can a patient take ruxolitinib? And I'd say independent of the reason, whether that's for myelofibrosis or even polycythemia vera, which is used in the States. At this moment, we do not have a time limitation. There are patients who've been on ruxolitinib since we first tested it in humans in 2007. And there does not seem to be any cumulative negative side effect that we find that occurs over time. So in theory, indefinitely, and we've not seen any evidence to suggest that there is a time limitation. So whenever there's a change in the vision, that clearly is deeply concerning and needs to be worked up well, and you need to have very good eye specialists to really try to understand what is the driver. MPNs can impact the vision, although it is in the minority. Sometimes it's because blood flow has really been impeded in terms of the retina, and we need to be more mindful of controlling the counts. Sometimes people have had blood clots to the retina or the back of the eye, and again, that's one set of circumstance. Interferon, in theory, can have eye-related side effects through inflammation or other type problems. So that too needs to be a consideration. It's not common, but it certainly can occur. So I think it clearly, in the context of both the hematologist, but really a true eye subspecialist would really need to be involved, because the two treatments really would be quite different. If it was really about controlling the counts better, it might be about more interferon. If interferon is really causing the side effect, that might be a strong reason to really discontinue the interferon and go on to a different therapy. So headaches are always a complex thing to sort out. One, they are common. Two, they can be problematic. Three, MPNs clearly can make headaches worse, although they typically, in particular people that were prone to headaches to start with, they make them worse. The medications clearly can aggravate headaches, as well as they can help them in certain ways. They can help by improving the blood counts that might trigger headaches, but they might have side effects in and of themselves. When it comes to medication-related side effects, given all these complexities, it's sometimes difficult to know. As you work with your headache specialist, your GP, and your hematologist to sort that out. Sometimes the only way we can really know is to try to have a break from the medication in question and use an alternative way of controlling the counts over a period of time to really see if they resolve. Clearly, our hope is that the difficulties that you're suffering from, we will find a way to alleviate them. There might be a variety of different contributors. One, the iron deficiency that phlebotomy leads to might be aggravating many of these symptoms. So that is a consideration for a discussion with yourself, your hematologist. Again, where individuals sometimes have begun on medicines to control their counts so we can improve the iron levels as they can worsen several of those difficulties. Uncontrolled symptoms in PV sometimes are reasons for consideration of either starting a therapy or changing to different therapies to see if another is a better fit. With PV, we have hydroxyurea, we have interferons, we have ruxolitinib. And they all have different implications, I realize well, in terms of obtaining them in Australia. But with each of these, individuals sometimes have found a good equilibrium where they feel well. So I would not accept feeling poorly with PV, and again, try to work through changing the medications to improve these things further. Our group is clearly looking at a range of ways to try to see, in addition, can we further improve the symptomatic benefit through yoga, through physical activity, through nutrition, through a range of other things. But I would do that only after we've perhaps optimized the medications. Unfortunately, I've heard this too often. And actually, the efforts of my group looking at symptoms for patients with MPNs really started from patients themselves telling me that I feel different than my blood counts reflect. I am more than just my blood counts. And this is very true. MPN patients have several challenges. One, how they feel is different than their blood counts. Two, they may be less ill than the other patients that their hematologists see in clinic because they're treating acute leukemia or lymphoma, and by comparison, don't always necessarily get the same level of intensity that those patients might, because the burden of the disease is different. The arc of the disease is very different. We are working on trying to develop for English-speaking countries, in collaboration with colleagues in the UK and hopefully here in Australia, an app to be able to have individuals track their symptoms in now our validated series of questionnaires, so that can be shared with your consultant in an expeditious manner. How you feel is just as important as the blood counts. So the blood counts do matter, your exam does matter, but how you feel matters. And how to convey that in a concise way that they can track has been part of the logistical challenge we've really worked through. How do we make your level of pruritus or itching just as relevant as your platelet count. So itching is a difficult and frequent symptom for patients with MPNs. And there are both physical as well as medication-related things which can help. One, water can be a trigger for some, and some have found alternative ways of drying have been helpful. Whether it's air drying, whether it's to avoid the rubbing. So things around bathing and drying, people have found differences that are helpful. The itching is real. The white blood cells we have found migrate to the skin, and it is a very real biological effect. It's not out of thin air, it's not in your head, it is a real biological symptom of the disease. UV light clearly is helpful. Now, UV light clearly can increase the risk of skin cancer, but without question, UV light can provide benefit, whether at the beach or in a tanning bed or other things. Clearly, always has to be balanced against suntan lotion and risk of skin cancers and family risk and other things. That clearly is one of the most potent because it is really helps to calm down those white blood cells that are right under the skin that are part of the problem. There are certain antidepressants that have an anti-itch benefit because of the inhibition of serotonin that have been beneficial. The antihistamines, and some have been beneficial, but frequently those have not been overly helpful, and they can be sedating. For extremes, clearly JAK inhibition has been a very potent inhibitor of difficult itching. So that is a consideration. If I have a patient who's failed other things and has difficult PVERA, ruxolitinib is a strong consideration. So our group became very interested in complementary approaches for several reasons. One, it was clear that due to the range of difficulties MPN patients face, solely adjusting their hydrea, their interferon, their ruxolitinib alone was not going to normalize things. Two, individuals have to live with these difficulties for an indefinite amount of time. It's not a question of, well, you're going to have itching for 2 months, you'll get over it, and then you'll be fine. So how we deal with them is important. Our group really, because of our efforts with patient groups and really spurred on by their interest and their guidance, helped to identify the difficulty of MPN symptoms, helped to classify them, and helped to understand them. So now our focus is, okay, now we know patients have these difficulties, what do we do about them? So I'm fortunate to lead a group of collaborators at several institutions in which we are investigating a whole spectrum of things in parallel. They range from things that are in the physical activity realm, from straight physical activity to yoga. Yoga itself overlaps between physical activity and meditation. We're looking at meditation. We're looking at nutrition and the benefit of an anti-inflammatory diet. And then finally, we're looking at a cognitive therapy that is called ACT, or acceptance and commitment therapy. It's a variant of what people likely have heard is termed as mindfulness. So how does one take the uncertainty of the future, which we know is a clear stressor within MPN, and help to encapsulate that in a way that can be managed, so that that uncertainty of what might happen in the future doesn't ruin what your day-to-day life is at this moment. Physical activity is crucially important regardless of where we stand with our health. And we've learned that there is a negative cycle that occurs, that you have an illness, so you're less active, and you're less active, so you feel worse, and it just spirals. And that's true whether you have very advanced diseases or very chronic diseases like an MPN. Now, I lost my father to lung cancer, yet even putting him on a walking program, even toward the end of his life, he was able to feel better. Did he feel normal? Absolutely not. He had a terrible disease, but it clearly helped. In MPNs, I think it's incredibly helpful. One, 90% of MPN patients have variable degrees of fatigue. And activity and structured, sustained physical activity is probably the single most important thing we can do. Now, the important thing is to realize that the activity that is helpful is not the activity of daily life. People say, well, I'm running errands, I'm in and out of the car, I'm up and down at work, I'm exhausted. That's activity, but that doesn't seem to help very much with this sort of issue. Well, these sort of things are helpful is sustained, uninterrupted activity for at least 20 plus minutes, whether that be sustained walking without stopping, whether that be an elliptical machine, whether that be at the grocery store, if people have inclement weather, just walking the aisles. Sustained activity is the most important. The degree of energy and focus by the scientific community and MPNs has never been greater. And it's brought together individuals that have a deep care to advance the understanding and treatment of MPNs to a much greater degree than we've ever had before. People who are studying everything from why do we develop MPNs in the laboratory to better treatments to things such as yoga, nutrition, etc. So I think a lot is evolving. I think communicating what is going on is an opportunity, but I think much more than we've been in the past. Engage foundations, the Leukaemia Foundation, parallel efforts in the United States, I think are spectacular. Live patient events, Q&A, all of these things. They're complicated diseases, and trying to complement the information that can be shared from just the typical visit with a hematologist is an important part. There's a lot of information out there. So it's important that all information that you digest, you do so really in concert and in partnership with your treating hematologist. Because there's a lot of information out there. There's a lot of accurate information out there. But not all that information is specific for you, or it might not be relevant for you. It might be for people that have a different disease or more advanced disease or a less advanced disease. So not only taking information but framing it in terms of what does that mean for you is a key part.